And welcome back, everyone, to Hotel Del Coronado. You're listening to the Really Is podcast. I'm your host, Kevin Edwards. Alongside me today, we have Radinsky, the Chief Technology Officer at Diagnostic Robotics. Kira, thanks for being with us today.
Thank you for having me.
So, Diagnostic Robotics. What is Diagnostic Robotics' role in healthcare, as well as what is technology's role in treating a patient's pain?
So we actually started talking about the problem that you all know of. ERs are completely overcrowded. People are waiting 3 hours on average. If you look at China, people are already waiting 8 hours. And the reason is till 2030, there's going to be 3.8 billion people without access to primary care. So the 3 hours we're waiting right now is nothing compared to what we should be expecting in the next 15 years. And usually when you ask yourself, why is that? What's going on in this emergency room? So we were trying to exactly answer these questions. Doctors usually saying we're missing 60 to 90,000 clinicians this year alone. And we're thinking, can we use AI and all of these encounters in the past inside the emergency room to start automating part of this process? So we did exactly this. We had access to 72 million different visits into the emergency room and primary care. And we started building an AI system that knows to ask questions from the patients, recommend which tests, and each time knowing who is really urgent, differential diagnosis, etc. And we started building workflows and automations inside emergency rooms. But then we realized something super interesting. No matter how much you automate inside the hospital, it's not enough. People are still waiting. And then we realized something super interesting. Turns out that 30 to 70% of the ER visits could have been handled from urgent care center or home. So we decided to take this system that we trained into the emergency rooms, that we started FDA process for that one, and give it a chance from home and help direct the patients to the right locations. So today this system is a decision support system for providers. It automates around 20 to 30% of the different interactions coming into doctors, and the other ones are with the decision support system with the nurse or with the doctor.
Okay, got it. Okay, so what you're saying is there's a low supply and a high demand of people,
Yes.
hence the wait room problem is an issue. Then you figured out, you know what, people don't even have to wait in the wait room. We can take care of them at the home. So you created a solution or recommended a solution to really bridge the gap between providers and patients,
Exactly.
if you will.
And I'll give you an example.
Yeah, please.
Let's say I'm not feeling really well at home. I have a low abdominal pain. I go on my provider app. So the solution I'm just mentioning is already with collaboration with 75% of the HMOs in Israel. Going in my app, the system is starting to ask me questions. Does it hurt when urinating? Do you have fever? Behind the scene, the system realized 60% that I might have UTI. It looked at my medical record, it looked at my history, it looked at my answers to the questions. What happens then? There is a rule that the provider wrote. It says that everything above 30%, he automatically approves me a urine test. Now the urine test, it's a sensor that can be sent to my home. So the providers are sending a sensor, it's an SLA of between 2 to 3 hours. You get a sensor at home, you do a urine test at home, you take a picture of the result. The system is reading the result as well. Now it changes the probability to 90% that this person might have UTI. And now depending on the provider, one provider actually wrote a rule saying that, well, if it is above 80%, connect a telemedicine doctor, and the doctor should approve antibiotics. And one of the HMOs did something even more futuristic. It says everything about 87% automatically approve antibiotics is being sent directly to your home in an SLA then of another 3 hours. So we're looking at an end-to-end solution from home of treatment that might be automated. And of course, UTI is a very special example. Most of the chances that it's not going to be completely automated, there's always a person in the loop. But I think this is where it's going.
Well, I think it's a great example because maybe someone would be embarrassed to go to a doctor because of a UTI or something like that. There's plenty of diseases that people would be embarrassed to go to the doctors for. Something that's interesting to me in tech is how it evolves and how it gradually comes out. And I think it's correlated with trust and it's correlated with a lot of different things. But the human aspect of that, it's like self-driving cars. They're not out yet because they can't predict humans. How do humans use this and harness your technology if they don't want to share or even, for instance, health? I'm not going to care about something until it happens to me. How do you predict a disease or a treatment using the technology that you have?
So I'm not sure that we can predict every type of disease, and I'll explain why. There's several protocols who are trying to prevent people from getting disease. So for example, people should have an eye check, specifically if they have diabetes. So there's certain protocols for that one. It takes lots of time to prove that this type of interventions are actually doing something good versus not. What we are capable of doing is proactive care, not about diseases, but about outputs. For example, we can predict who's going to go to the emergency room in 3 to 6 months. Why would we do this? Because then the care manager can actually contact them, try to understand via conversation what's wrong with them, schedule a PCP appointment, or help them with the drugs if they're seeing they're not buying drugs, additionally with all these historical care gaps. So this is a system we've already deployed. The next steps of it is trying to actually automate a lot of these processes. Today, there is pretty much 4 care managers per 70,000 people, which is very low if you think about this. If you look at a PCP, there is 1 PCP per 5,000 people.
Jeez.
In Israel, for example, it's per 1,000, and we're still not happy about that. And the reason is population is growing. Okay, we cannot forget about that one. Okay, this is why all of this technology is helping us with the scale of people that the PCP has to take care of.
And so with this rising scale, I guess maybe the better question is, have you found it challenging for the humans to adopt this new technology, the providers to adopt this new technology?
Of course, it's not clear. If you have a system saying that this person, 60% they have pneumonia, would you use it? No. Because why? Why 60%? Where did you get this number from?
Right.
And this is where we realized that if you just build a black box and give it to a provider, it's not going to work. So we started building explainable machine learning algorithms. And this is super hard because machine learning is built before that as just a correlation machine that spits out a probability without any explanation. Instead, we started building different machine learning compression models that learn both explainable models with very complicated and best performing models like deep learning. So eventually, when we give a probability, we even say why. For example, we can say it's sinusitis because it hurts when they're leaning the head forward, that he has a cold and stuffy nose. And we can even say which parameters lower this probability. What they do with this, it's still their decision. It's a decision support system. But without this extra understanding of the doctor of what's going on, this was super hard.
Kira, you're a machine. You're handing out all these, passing up all this information to me. Some of it's going over my head, some of it I'm digesting myself, but I'm more curious about your background in this. Why are you so passionate about this subject, and why are you on a quest to solve all these different issues and problems?
So I started with another quest at the beginning. I know it's going to sound weird, but when I started my PhD, I wanted one thing. I wanted to predict the future. So I started building a system that tries to take everything humanity ever built. So news articles for the last 150 years, Twitter, search engine, queries, etc. And we built a system that looks for patterns in history and tries to predict future events. We did really fun stuff. So we predicted the Sudan riots in 2013. Turns out the system identified a pattern that if you have a subsidized product, you stop subsidizing it, people are going to go to the streets, specifically young students. If one of the students gets killed by the police, we're going to have major riots. So what happened, the system learned this from past experiences, like in Egypt, where bread prices were subsidized, stopped subsidizing them, people went to the street, and mayhem. And then it predicted the Sudan riots. Why? Because gas prices were subsidized, they stopped subsidizing them, people went to the street, and then 2 to 3 weeks of different riots. But then one of these predictions actually caught my attention. We were trying to work with different aid organizations and trying to predict different types of diseases. Specifically, one of them asked us to help predict cholera outbreaks. And the reason is because there is very clear intervention. If you predict cholera outbreak in time, you can drop mortality rates from 50% to less than 1 if you get clean water in time. So we started building this system to identify the pattern. And the system identified a very interesting pattern. If you have a drought, and 2 years later you have floods, these floods, in more than 84% of the times, can cause the cholera outbreak. Now, if you predicted 2 years in advance, the aid organization is not going to do anything about this. But what the system helped us understand is there's something in the weather that correlates or maybe even causes cholera. So we started getting information from sensors from all of these airports. Airports are keeping information on an hourly basis on the weather since 1970. We got to the World Health Organization, asked for every cholera outbreak that they knew about, and started correlating this information. And that's a very interesting pattern that happens a few weeks before the cholera outbreak, specifically 2 to 3 months. And this is where I realized we have so much data that we can have real impact on lives. But it's not as simple as it sounds. I had a friend, he was trying...
Doesn't sound simple.
Even when you predict something, the intervention is super hard. One of my friends, he was trying to predict and when you have natural disasters, he wanted to send aid to people who actually need it. And they showed a very nice correlation that if people are tweeting that they need help, most chances this is exactly when most aid is needed. Until Hurricane Katrina. In Hurricane Katrina, people who actually needed the help were not tweeting. Why? They didn't have electricity. The main and big problem of all of this AI system is how to apply them. Because it's not clear that the distribution is so similar to how we train versus how much apply. But this got me exactly to healthcare. And I was intrigued by the problem and the impact it can have on humanity. I don't know if we're going to change the entire world, right? But I want to give my smallest contribution with a single step.
Well, this is what I want to ask you about the application of it. You mentioned China. You mentioned a lot of different examples. You mentioned water challenges in different countries when you're trying to solve and figure out some of the world's patterns. The application of this technology that you're dealing with, how does it vary from culture to culture?
Super interesting question. We actually tried it out. We tried to take our machine learning models and apply it on different data, like Singapore data. Completely different distribution. We applied it on even 19-year-olds, healthy males in the army, and compared it to a random hospital in North Israel, one of the largest ones. And we see that the model performed very well, even better than the model trained on the data from Singapore. And the reason is, most of these people were healthy. The classifier should have been very paranoid, but you can be very paranoid only if you work in hospitals. So it turns out that in certain questions, in kind of a retail problem / urgent primary care problems, there isn't significant difference between different cultures. There is difference in treating chronic diseases, but we're not even aiming there. You have a new problem that you didn't even experience before, then these models can answer this across culture.
In terms of technology's role in the progression of humanity, you talked about big differences, that people who had access to money were able to get these diseases. Technology is the same way. If you have more technology, you can use it as a tool or a weapon. What are some of the conversations that you're having amongst your staff, amongst your peers, your colleagues, your friends, about how technology can be used as a force for good?
So in my way, I think we're actually enabling better care and more fair and more equal. And I'll explain. If you're living in the suburb very far away from a large hospital, you're not going to get exactly the same treatment as people living next to the best hospital. People not in the United States are not going to get exactly the same treatment as people inside Mayo Clinic. So how do we build a system that learns from the best doctors in the world and actually distribute this to everybody, so everybody can have very similar care? Or at least given as a decision support system to every doctor. So this is where I see our benefit, actual democracy of health data.
Democracy of health data. And that's through this digitization, and that's through private health records? Is that through blockchain technology? What does that look like in your ideal mindset?
So you're talking about the implementation of this. I'm actually talking about the concept, about taking a system that's trained on the best doctors so it can actually mimic them with a correlation of more than 90% and give this knowledge per case to each doctor on the planet.
I like that.
So in other words, it's actually you getting the best doctors to everyone in the world, no matter where they live, no matter who they are, without any difference.
Kira, that sounds like a world I want to live in. And Kira, you talked a lot today on the podcast about the vision. And the vision is a great trait of leadership. So last question I have for you, Kira, is what is your definition of a real leader?
A real leader, after he falls, knows how to get up. And actually helps everybody get up with him, with a great vision of doing one step to move humanity just a little bit forward.
Kira, appreciate your time here on the Real Leaders podcast. Spoke a lot today about not only your operations, how data is being harnessed to help out and bridge that gap from the provider to the patient as well. Talk about your experience, your background, how you had the thesis of what if we could predict what's coming next in the world, and studying all those artifacts as well. We talked a little bit about technology, how it can be harnessed as a force for good, and lastly, your advice for other leaders around the world. For Kia Radinsky, I'm Kevin Edwards, asking you to go out there. When you fall down, get back up, be a leader, and always, people, keep it real. Thanks, Kia. Appreciate you.